angioplasty and stenting has been done on dual antiplatelets. He also has pectus excavatum with moderate restrictive lung disease, and he is having severe pulmonary hypertension. Pre-op cardiac status on echo, he is having a akinetic LAD territory with a biventricular dilatation and failure. LV dimensions were 68 and 48 mm with RVS FAC of 25% and a grade 3 diastolic dysfunction. He also has a moderate MR and moderate TR with a global systolic dysfunction, severe PAH with RVSP of 80 mm Hg, almost 70% of the systemic pressure. Pulmonary, he was having pectus excavatum with a restrictive lung mechanics. So he was having reduced FRC with poor compliance, high risk of hypercarbia and hypoxia. So there is a severe PAH. So he was also having a risk of acute RV failure. So preoperative status, patient was having exertional dyspnea with limited functional capacity, optimized with post-dialysis uremic status, and he also was having anemia of CKD with 8.6 and normal electrolytes post-dialysis, persistent high PA pressures even after dialysis. So what are the major perioperative risks? I think can discuss with this. Key doubts in managing these patients. I think I'll open this discussion to the panelists. Can this patient safely undergo renal transplant? Can any of the panelists discuss on this?
The first question is this patient a candidate for renal transplant? He's got severe LV as well as RV dysfunction, plus renal failure, diabetic. So,
whether he's a candidate for renal transplant?
For renal transplant is what's my question.
Or he is a candidate for both heart and renal transplant?
So cardiologist, if this patient, you put a new kidney inside him, will that kidney function with severe LV dysfunction?
Yeah, the same thing we discussed with this case a few days ago, whether this patient is really fit. But then just I asked post-operative course and all. See, whatever dialysis and whatever, the patient was doing well for quite some time. So after the procedure, because it's a double insult, and then once you do this, the RV dysfunction, whatever it is, it may not progress or it may at least halt. The most important reason is he was quite young relatively, right? He was around 45 years. 45 years. That was the main reason to give a chance and then see with the people. Otherwise, the mortality, if it is more than 1 year, we can probably give a good quality life. That is the reason.
Suresh? We did a couple of cases with this almost same scenario with a severe PAH. The first case I was literally worried. I also asked the nephrologist and cardiologist, will he come out? But to my surprise, once the kidney started functioning, the RV pressures will come down. I put a PA catheter in this type of cases, PA catheter in the before induction itself, continue it into the post-operative period. As of course, they will be on the anti-PH medications also like tadalafil and all. We continue that into the post-operative period, but it comes down. If the kidney is functioning well, the PA pressure tends to come down. Even LV function also improves. That's cardio-renal.
Yes. The second question is on table. Once the kidney is placed, you have to give lots of fluids to the patient. And he's already got severe pulmonary hypertension on the verge of RV failure. So, will that tilt the balance during the intraoperative period?
Kidney starts functioning and pouring out adequately rather than having imbalance and then intermittent dialysis where there will be a lot of fluid shifts and all, where the insult will be more on the RV function. If it functions well, pours out a lot of urine immediately, that will definitely reduce. That's what we thought. And age was the only factor. In fact, we had a discussion about this case a few days ago. Was it really? Then age and then, some cases do respond after this. So it happened, and patient was leading good quality life and for quite some time.
So another question will be, how to manage the RV collapse during induction and intubation, which are triggers of catecholamine release. So that is also one of the concern in this patient. So how to manage the SVR PVR balance? It's a question to anesthetist panel.
Inhaled prostanoids, have you tried to reduce transiently the pulmonary arterial pressure?
How about 100% oxygen, sir?
Yeah, it may help to some extent, but inhaled prostanoids are indicated in such cases to transiently reduce whenever there is an acute insult in PIH.
And theoretically, at least, my concern would be that, see, you have RV, severe pulmonary hypertension, you reduce the pulmonary vascular resistance. On the other side, on the left side of the heart, you have a failing heart. You are going to get more transpulmonary flow of blood. How will the LV accept this just before the transplant I'm talking about, during induction? So if you use inhaled nitric oxide or prostanoids, as he mentions, you reduce the pulmonary vascular resistance, there is increased transpulmonary flow of blood. Is the left side going to accept this additional blood flow?
This is an ideal case for the paraoperative transesophageal echocardiogram, where you can clearly see the preload and then the afterload and then dimensions of the vessels. So you have to be very, very cautious, and then closed loop fluid management in such a case would be better.
And what would be the ventilation strategy in this patient? How to ventilate with, provided the dynamics of RV, LV will fare with the positive pressure ventilation, but RV will not fare with the positive pressure ventilation. How to maintain the tidal volume and PEEP, and how to maintain normoxia, and how to prevent hypercarbia.
I think the present strategy would be to use protective lung ventilation, use 6 ml per kg and a little higher PEEP. That, see, the PEEP will not be adversely affecting the pulmonary vascular resistance, because many of these patients will be having a lot of pulmonary congestion or pulmonary vascular, and pulmonary vascular resistance is least when we have the best PEEP. So you have to titrate your PEEP and use protective lung ventilation. That would be my strategy. I don't know how others would like to do. Are the other anesthetists in the group? Raju, Mahesh?
Yeah, I think Suresh, what you said is right. I think the trick is to use the moderately low tidal volume, moderate to low tidal volumes, and ensure that you also accept a little bit of hypercapnia. You don't need to really be too much worried about it. I'm not saying
What
60
will
or
be the
65
target
plus.
PaCO2?
Pardon?
Target PaCO2?
Yeah, maybe up to about 50, 55. Shouldn't be a problem in this case to an extent. Because what would probably hurt the RV is the high tidal volumes and high peak airway pressures.
So plateau pressures will try to
Plateau pressures also, yes.
come.
Limit to about maximum of 20 centimeters.
25 can accept.
Yeah.
Yes.
Yeah, we can proceed, Dr. Loganathan,
Yes.
so we can have questions.
So based on the discussion, so in this case, what were the physiological priorities were to maintain the RV perfusion? So maintain the MAP of 70 to 75 and avoid increasing in PVR. So we should avoid hypoxia, hypercarbia, acidosis, and also hypothermia. And we should avoid excessive PEEP, and we have to maintain a sinus rhythm to maintain a RV preload. So atrial kick is very important in RV, and heart rate control is also important. For graft and renal perfusion goals, we have to again maintain MAP, and we have to avoid hypotension, long periods of hypotension during reperfusion phase, and dynamic assessment of fluid responsiveness, and we have to prevent acute RV decompensation. So how we manage this? We have placed IV line, arterial line, and a PA line before induction, and we have induced with ketamine, low dose ketamine with a fentanyl of 3 mics per kg to avoid the tachycardia by ketamine. And we add a lung protective ventilation with low tidal volume with moderate PEEP, and we maintain normoxia. We avoided hypercarbia, maintained an PaCO2 of 35 to 40. And we have carefully titrated the volatile agents. And volatile agents, isoflurane was kept at 0.8. And careful titration of anesthetic to balance the bioventricular function. Maintain MAP of 75 to 85 and balanced fluid. So we avoided overload and maintained a narrow margin based on the PA pressures and pulmonary capillary wedge pressures. We didn't have TTE, so TE, we had TTE, transthoracic echo. So based on that, we had fluid management. Intraop, we have used a low dose norepinephrine. Post-operatively, there was a little lactate rise with a low mixed venous saturation. So we have kept a dobutamine for a day. Post-operative patient extubated after 6 hours, and he was doing well. Discharge after 16 days, and follow-up echo also was showing decreasing TR gradients, that is decline in PA pressures, improving RV function, and LV dimensions after 2 months were 58 and 43 mm. So though there is a improving cardiac function, patient unfortunately expired because of neutropenic fever and sepsis after 2 months of transplant. Thank you. Anything?
Thank you, sir.